Welcome to EMN5. My name is TJ Welniak. I am an emergency medicine attending physician at Maimonides Medical Center in Brooklyn, New York. I'm going to talk briefly about how you, as a physician working in the emergency department, can improve your patient's care by communicating more effectively with other physicians using a couple very common mnemonics that are out there. Now picture this, you're in the ED towards the end of your shift. You just started to work upon a patient and won't be around to make the decision on disposition once all their labs and studies are back. Henceforth comes the handoff, arguably the most important part of your shift. You're going to need to tell the oncoming physician about your patient such that they know what they need to know to continue the assessment, treatment, and ultimate disposition of that patient. Now, ordinarily, a lot of us rely on techniques learned on the fly during training and from those around us. But it remains that many errors happen during and after this transition. Now, one way to add some structure to this is to incorporate the use of a standardized system, a mnemonic. Now, there are dozens of these floating out there, but we are going to burn through two of these in particular that you or your hospital might be incorporating as we speak. I'll add in a caveat that I don't believe that any of these mnemonics are perfect or are highly validated for the ED setting, so use your best judgment. But if you have a consistent approach to this every time, then the chance of information being lost or misinterpreted really should go down. Now, the first tool that you might be aware of is called Ipats. Now, this was developed by a group over at Boston Children's, but I think it has some applicability to shift change in our own ED. So the mnemonic goes like this. The I stands for illness severity. Here you are telling them right off the bat if this is someone that they should be paying a little extra attention to. The P stands for patient summary. Now, this is not a patient presentation as you would do for an attending on rounds or anything like that. You were telling the story in a relevant fashion of why the patient is here, what happened that brought them to the emergency department, what has been going on while in the emergency department, what studies have you gotten, what treatments have you tried, and how have they responded to those. The A stands for action list. Here you're giving the oncoming provider very specific things that they should be following up on, whether it be CAT scan results, a consultant's recommendation, reassessment after an intervention. The fact that there are things that are still incomplete and needing to be accomplished is the whole reason that you're handing them off to another provider. The first S stands for situation awareness and contingency planning. This is where you're going to talk about the very important bits of information, such as if the patient is DNR, if they're coming in from a shelter or a nursing home, if they live alone, if they've endorsed any psychiatric symptoms such as suicidality or are needing a medical hold. This is also where your if-then recommendations are going to come into play. If the patient still has pain after this particular intervention, then do this. If it shows up that they have an appendicitis on their CAT scan, call surgery. If they become hypotensive, give them fluids, give them pressors. This is really where you can help the oncoming provider understand this patient in case things don't go as expected. The last S is very important. It's synthesis by receiver. Ideally, this is in the form of closed loop communication where the oncoming provider essentially summarizes what you just told them. This pushes out any possibility of errors in understanding and solidifies that oncoming provider knows now as much as you do in regards to the patient and is understanding of the plan that you both have set forth with this patient. Again, I think this mnemonic is a bit better for your end of shift transitions. I'll generally use a different mnemonic for my transitions of care between departments. For this, I'll use sort of a modified S-bar mnemonic, S-B-A-R. The S is for situation. Here's where I will identify myself, confirm the identification of the call recipient, and quickly state my reason for calling them. If it's for an admission, I'll identify the patient, their medical record number, and state what my admission diagnosis is. The B stands for background. This is where we'll discuss the relevant findings from the history and physical exam, the relevant results from our diagnostic testing that we've done. A stands for assessment, and I'd like to add in activity while in the emergency department. Here's where I will talk about the emergency department course, where I will address their overall severity, stability. We'll talk about the interventions that we performed in the emergency department, their response to those, and our working differential. The R will have stand for risks and recommendation. This is where we will talk about our anticipated course, those special considerations that we addressed earlier, such as DNR, language barriers, psychiatric and social issues, as well as identify the pending tests and definitely assign responsibility for who's going to follow those up. Now, at University of Nebraska, they've added 2 more letters to the mnemonic, a D and an R, so S bar doctor. The D is standing for discussion and disposition. So this is the opportunity to respond to questions from the accepting MD and agree on the ultimate disposition. The R stands for responsibility of care and readback. So getting back to your closed-loop communication, where the accepting physician will summarize the case back to the ED provider and will confirm responsibility of care as well as responsibility for pending tasks and tests. So that's a summary of some of the common handoff mnemonics that you might come across in your practice. It doesn't necessarily matter which one you choose as long as you have a standardized way of doing this so you can ultimately do best by your patients. Thanks for joining us on EM in 5.